External Affairs at the McSilver Institute at New York University and a part of the MCTAC team. Welcome to today's webinar, the workshop overview and anatomy of a contract presented by Adam Falcone from Feldman, Tucker, Leifer, and Fidel. So today we're going to be talking through, as a continuation of our contracting series, the anatomy of a contract and introducing an assignment that providers and agencies can do as a team to help to solidify your own experience and your knowledge of contracting in a managed care environment. So I'll fly through this pretty quickly. I know a lot of folks on the line are familiar with our work, but just for the few folks who this might be their first MCTAC training. So MCTAC is a training, consultation, and educational resource center that we offer resources to all behavioral health agencies in New York State with the goal of preparing everyone for the upcoming transition to Medicaid managed care. And so under that line of work, we're providing foundational information as well as tools, resources, trainings and workshops like the one today, a number of learning communities, in-person events, large format, and then we always look to provide aggregate feedback on the state of readiness to providers and state authorities. So who we are, we're quite pleased to have pulled together an amazing team of academic, provider, advocacy, and research groups from all across New York State. That includes CCSI up in Rochester, Casa Columbia based here in the city, who is a substance use provider-focused research organization, the Institute for Community Living, IDEAS, and NIAPRIS. And then just as a quick refresher, the previous contracting trainings that we've held, Adam Falcone joined us for a remarkable series of 5 in-person sessions back in the fall and early 2015 that were attended by over 600 people, despite some pretty inclement weather both in New York City and Albany in December and January. But so those were held in Rochester, Long Island, in the city, and in Albany. And 93% of the feedback form respondents at the end of our events, if you've been to an event, you know the standard feedback form that we collect that we use to inform all of our trainings, and is one of the reasons why we've brought everyone back together today. Found the in-person contracting sessions with Adam to be useful. So that was no surprise to us. We're thrilled with the job that Adam is doing, and we're so pleased that he's joined us again today and for this workshop series. We also recently held an event in partnership with the coalition here in the city, a contracting fair where providers were able to go around to the different MCOs and network and build relationships and start to talk through what the contracting process will look like. And then we also offered 3 web-based presentations. Back in December, Managed Care Contracting, the Plan Perspective, Contracting Overview and Office Hours with Adam, which helped to supplement the in-person piece, and then Managed Care Contracting, the Provider Perspective. And I mention all of these resources just to encourage folks, whether you need a refresher or whether this is your first time at a MCTAC contracting event, to please look at our website. We have all of the slides and recordings of these respective events, except for the fair, obviously, all there online and available for you to review and help to use to guide your process through this workshop series. So for those who are familiar with the Managed Care Technical Assistance Center, we have a Medicaid Managed Care Readiness Assessment that folks can fill out, send back to us, and then we benchmark responses to your colleagues and counterparts across the state to give folks an idea of just about where they perceive themselves to be with the broader system. And so there's a lot of numbers and words on this slide, but what the takeaway is that, you know, when we look at people and specifically around contracting and whether they're definitely ready, a little bit ready, not at all ready, it's a pretty even spread around the board. And so we're going to do as much as we can in this workshop series for the people who think they're a little bit more ready for contracting with managed care, to provide a level of expertise and guidance that's appropriate for them. And for folks who've never contracted with Medicaid or managed care in the past, to make sure that we're covering all of the bases and providing the supports and resources that those folks need. Also, in addition to the contracting series, we'd also strongly urge people to review the kickoff series slides and presentation back from the fall, which Adam obviously covers a lot more of the contracting details in depth. But if you're curious or unsure where the world is heading, that's a great place to start. And so we were thrilled by the response we got to the workshop announcement. We have 250 unique agencies, organizations represented with this workshop, and that represents over 500 individuals. So we were thrilled to see so many agencies signing up and interested, and we were also really happy to see that within each agency, multiple people would be participating in some format. We'd imagine that maybe there's like a delegated lead that's probably on the webinar today, and then you'll be taking this information back to work through the assignment that we'll be running through a little bit later. But with that said, this is a very conducive place for a team building approach. So just a quick run through of the numbers. So over 2/3 of the participants are licensed by OMH, just under half by OASAS, and a smaller percentage by OCFS. And then also interestingly, almost 60% of the participating agencies in this workshop have contracts in place with respective MCOs. That might not be all of them, but as we like to say, there's never a bad time to think about your approach to contracting. So with the no group, that might be a representative of folks in the city who still haven't had a chance to work with their MCOs to enter formally into contracting. That also might be a good number of folks outside of New York City whose implementation timeline is a little bit further down the road. And this is just a quick look at the folks who are participating, who have participated in a previous MCTAC contracting offering. So the in-person events that were mentioned, the webinars, the contracting fair, and then most interestingly, 40% of the folks who are participating in this have not yet had a chance to participate in a contracting MCTAC offering. So that doesn't mean that they didn't come to a kickoff or fill out a readiness assessment, but so we really just want to take the chance to reiterate and reemphasize how important it'll be and how useful it is to take a quick look back, in addition to the webinar today, at some of the materials that have already been done. They're great resources, in particular Adam's in-person presentation that ran through negotiating basics and leverage and a whole host of different issues. So with that, I'll just quickly outline what we'll be doing here. So today is the anatomy of a contract and introducing a team-based assignment. And so after today, the participating agencies will review the assignment, or the exercise as we'll call it, which is a sample contract that folks will be working through. And then we encourage folks to send questions to mctac.info@nyu.edu, which is our standard email address, which many of you have probably reached out to us using, with a subject line specifically contracting workshop assignment, just to help us keep things organized. And then that will help to inform, in a couple of weeks, an office hour where we'll run through all of the questions folks have about the assignment and the exercise, give a little bit of guidance if specific areas are particularly tricky or unclear. And then we've allotted another week and a half after that for participants to finish the assignment, and then we'll set up an online survey tool for folks to submit their responses, and then ahead of a final wrap-up with assignment review, final questions and answers, we can identify some of the trends and really go back through some of the specific provisions of the template contract that were tripping people up a little bit, or that folks have questions about. So again, we strongly suggest reviewing slides and recordings of the kickoff series and Adam's initial training. The contracting exercise itself, I'll quickly just say a couple of words about. So Adam has pulled together a sample learning lab, so to speak, template contract that is something that similar to what you might expect to receive from a managed care organization. It runs through 5 sections of provisions with anywhere between 4 or 5 to, I believe the most is 13 items per section. So the sections in order of appearance are definitions, provider obligations, billing and compensation, term and termination, and general provisions. And then there's also a product addendum at the very tail end, as you often might be familiar with. So again, we'll be, in terms of just the timeline of all of this, we'll be following up from this webinar with an email with a recording and the slides from today, a link to a PDF of this template contract, a tool that you can use in real time as you're working through it with your team, a hard copy to kind of make some notes on, and then a link to the survey where you'll actually be importing or inputting the data or the responses to the assignment. And so with that, I'd like to quickly introduce Adam, and then we can jump into the content of today. So again, Adam is a partner at Salzman, Tucker, Leifer, and Fiddle. And he has both an MPH and JD, which we find to be very exciting and impressive. So in addition to being considered one of the preeminent experts in managed care contracting, from the very get-go, he's always had a passion and an interest in healthcare systems and public health. So again, it's no surprise that 93% of the people who attended the in-person session found it to be useful and helpful, and we're really drawn by Adam's passion for this work. And so without further ado, I would like to turn it over to Adam.
Great. Thank you, Dan. Thanks for that very kind introduction, and thank you to the McSilver Institute for putting together what I think is going to be a fantastic workshop in developing your skills to evaluate a managed care contract. And good morning to all of you. I should say at the outset that my challenge this morning is probably not an easy one. It is, in short, to teach you how to read a managed care contract without putting you to sleep. Many of you may have tried to do this on your own before, and your eyes might have started to glaze over before you even made it out to the second page. Honestly, I don't blame you. When you read a document whose structure is unfamiliar, which uses language that is, let's be honest, not exactly how people talk in the real world, and without an idea of what to be reading for, it can make basically for great bedtime reading, and will put you right to sleep. So what I hope to do today is to explain to you how these contracts are structured, where to be looking for certain things, and what to be looking for as you make your way throughout the contract. Knowing this may not turn the MCO contract into an overnight bestseller, but it should help you keep your eyes open and make review of the terms themselves more meaningful. So let's just get into it and start first with the structure of a managed care contract. In my view, it helps to actually think of it having 4 distinct parts. We'll talk about each of these parts in a little bit more detail as I move through the slides. But I think it helps to break down the contract into 4 pieces and understand how they interrelate. First up is the header and recital section. If you think of a contract as telling a story or a play, this is where you find out who the characters are and why they have come together to make promises to each other. This part of the contract may not actually be legally binding for the parties, but is certainly helpful background information, and in the event of any legal dispute, it could inform the judge's decision, much like legislative history helps judges interpret the meaning of statutory provisions. Second is the contract provisions. This is really the meat and potatoes of the contract, and we'll go through how this contract provisions are ordered and what to look for later on. Third is the exhibits for the contract. This is where any of your managed care contracts are customized for you as the type of provider that may furnish behavioral health services as opposed to physical health services, inpatient versus outpatient. This is where your fee schedules will be found, any regulatory appendices and provisions. It's all in the back end in the exhibits. And you might think that this is actually where all the good stuff is. That's not a bad way to look at it. But it's also where you have to make sure that you're having all the relevant exhibits as well. If you're a managed care company, you may have 15 or 20 different contract templates for different providers out there. And then after that, you might have several different types of exhibits that you might throw in, depending on what product the contract is covering, whether it's just a Medicaid product versus a commercial product or workers' comp. It might have different fee schedules for different types of providers. And even for the same provider, there could be different fee schedules that they offer. So this is sort of where the mix and match part comes from the MCO's perspective. And so you may want to make sure at first that you have all the missing pieces, all the relevant exhibits that are referred to in the contract. And we'll talk more about that later on as well. And then fourth are the documents incorporated by reference. I call this hidden terms because one way to think of a document that's incorporated by reference is that that document is now part of the contract. It's legally binding. That's what it means to incorporate a document by reference. And there could be many documents that are incorporated by reference. It could be the provider manual that is typically incorporated by reference, but there could be other policies and procedures, or credentialing manuals that are incorporated by reference as well. And these are often important to look at in understanding the minutia of actually how the plan wants you to credential your practitioners or how they want you to submit bills and claims and what the process is for appealing issues or for seeking prior authorization for services. So these are important documents. They're not found in the contract, but they basically have the same effectiveness as any terms that are actually in the contract itself because they're incorporated by reference. So looking at the headers and the recitals, the header is actually just the parties to the agreement. You'll typically see something that says, that has language as this agreement may be called something as effective on such and such a date, and it is involving this party and this other party. So when you're looking at the header, first make sure that it actually correctly identifies you under your legal name. You may have a different doing business name or trade name as opposed to your legal name. It should refer to your legal name because this is a legal document. And you can also see who the other entity is, what plan it is, what their legal name is. Often it identifies the type of legal entity for a nonprofit versus an LLC, a limited liability company, or even a for-profit. The tax status can have some significant consequences in some transactions, so it is helpful to know what the tax status of the parties are. Here you might find the effective date, or at least when the contract is made. So this is the making date, or it could be the effective date of the contract as well. Sometimes you'll see retrospective contracts, so it may be signed on July 15th, but it has an effective date of January 1st for that year. There's nothing unlawful about doing that, but so you want to clue into the fact about when is this contract actually effective between you and the MCO. And then third are the recitals, and as I said, these may not be legally binding, but they help set some of the context and should explain the purpose of the parties coming together for the agreement. Next, you come to the contract provisions themselves. I've looked at a lot of contracts, and honestly, they're set up and ordered pretty much the same way. And you will find as you look at different managed care contracts, the same thing to be true. So I wanted to set out sort of what the typical order is of provisions that you'll find in a contract. First, you'll find the definition section. That's usually up front just after the recitals. Next, you'll see a section typically that relates to you and what your obligations are, what rights you have, what representations you might be making. Third are the payer's obligations or the MCO's obligations. That could extend to paying you, which is very important. It could also mean representations that they're making to you about what they plan to do or warranties and what their duties and responsibilities are under the contract. Typically, this is a much shorter section than your section of provider obligations. Fourth is compensation and billing, and I'll be reviewing each of these sections in more detail. Fifth is insurance requirements, malpractice insurance perhaps, that you are required to have, maybe sometimes in some contracts, general liability insurance, sometimes car insurance or automobile insurance if you move patients around. Sixth is indemnification. I'll explain what that means later on. 7, records and confidentiality. 8 is a section on dispute resolution. And then 9 is the term of the contract and termination rights. And then 10, I just call it miscellaneous. You'll see provisions there that I'll talk about later. This could have anything to do with amending the contract, assigning the contract, what state law applies to govern disputes under the contract, many of the standard terms that you'd find in any legal agreement. I bucket just as a miscellaneous, and those tend to be at the end of the contract. So let's look first at the definition section, though I might point out here that you don't necessarily have to read the contract in order. In fact, one of the things I hope you get from this presentation today is that just like reading your Sunday newspaper, you don't have to start with the cover page. You can go right to the sports section or the comics section or whatever other section may have the most interest for you. And I find often that it's not worthwhile looking at the definition section first. That's because if your contract is written by and been drafted by lawyers, which typically these are, lawyers will capitalize in the contract any terms that are defined in the definition section. Let me just say that again because I think that's really important. As you look through the substantive provisions of the contract, you'll see capitalized terms. Those capitalized terms are capitalized because they are defined terms in the definition section. And in my view, it's much more meaningful to review a term in context. So I usually skip over the definition section, and then when I come to a capitalized term in the substantive provisions, I refer back to the definition section to understand what it means. So you'll have various terms defined in the definition section. Clean claim, which is very important about when a claim is clean because that triggers how much time the plan has until they must pay that claim. Covered services, emergency services, what the definition of medical necessity is, what a member is, who a member is, participating provider, product provider, provider manual, QA programs, utilization review programs. These are all types of definitions that you'll find, and some of these, you'll find other terms as well in the definition section. So let me give you some examples for what you might want to look at in one of the definitions. Covered services is often defined in the definition section. It's important when you're reading the contract to distinguish between the scope of services and covered services. To make things easy, covered services are the benefits under the MCO's insurance product. As you know, insurance products cover different things. Medicaid might have very good coverage and cover a lot of different benefits, while commercial coverage may have less. So covered services are just what the plan covers under that particular benefit plan. Scope of services and contract, which we'll come to later, is what you're agreeing to provide. So something has to be within the scope of services and covered services in order for you to be paid for the service under the contract. How would you know what's covered? Well, this is where you may have to ask the plan for additional information. Every product that a plan offers could have different sets of benefits. Just like you're familiar probably with your own employer having different benefit plans or maybe different products, different benefits as opposed to an HMO versus a PPO. The same thing is true from the managed care contracting perspective with their providers. Since it's not in the contract itself, you should feel free to request a copy from the plan of what services are covered, what's in their benefit package. In addition, when you don't have a covered service, when you provide a service that might not be within the benefit package, typically you'll want the right to charge the patient for that service if you think it's an important medically necessary service, even if the plan doesn't cover it, and you'll want to have the right to do it. Let me give you a couple of examples from New York State that I've recently encountered with some agencies there. You may be familiar with the service that's coded as H2011 for crisis intervention. Well, Medicaid covers this service, but not all the commercial plans do. And so when you see the definition of covered service, if it refers to a fee schedule that's in the appendix, this is when you'll want to go to that fee schedule and see which codes the plan pays on. And what you might find is that while the crisis intervention service is covered under their Medicaid product, they do not cover that service under their commercial product, which means that if you provide that service, it may well be medically necessary, but it may not necessarily be paid by that plan if you see a commercial patient. So it's very important to look at the fee schedule in conjunction with covered services because it tells you what codes they'll pay on. In addition, you want to make sure that you can bill the patient, as I said, if it's not covered. But here, plans sometimes in the covered services definition impose some more stringent requirements for when you can actually bill the patient. In one case, one contract I recently reviewed, it said that you couldn't bill the patient for a non-covered service unless you notified the patient in writing that the service wasn't covered. The patient then had to consent in writing to have the service performed, and then at least 24 hours had to pass between delivering the notification and rendering that service. In my view, that would be a very difficult provision to comply with in order to actually charge the patient. I think in many cases you might find that actually completely impractical. So knowing that at the beginning should help you decide whether that's a reasonable provision in your contract, one where you might want to push back on at the contract to the plan and say that needs to be revised to be a little bit more practical and why the way it's written does not make sense for you. Another definition you'll find is the definition of provider manual. It's important here to actually be aware that some substantive provisions can kind of be masked in some of the definition sections. For example, it might not just define what the provider manual is. It might also say in that definition that the plan has the ability to revise that manual at its discretion at any time without advance notice to you, the provider. And these terms can affect things that are important to you, like getting credentialed, the QA program, utilization management, or claims payment. So these can really affect your substantive rights for getting paid and your responsibilities. I always say that it doesn't make sense to have plans change a provider manual if there's not a requirement that they inform you and give you advance notice of that change well in advance of the effective date that they want that to be effective. There's no way to be compliant with a change unless you know about it. Recently in a contract I reviewed, it said that the provider manual is incorporated by reference and can be amended from time to time. There was no notice provision provided at all in that definition. Another contract said that it's in the definition that failure to comply with the manual requirement may result in denial of payment or even termination of the agreement. And this is all in the definition section, and it's a way that the definitions kind of creep over and have real substantive impact on you. So they're important. So even if you come back and read them later, make sure you read their full definition to understand what it's actually saying. Medical necessity, very important term. In most commercial contracts, the plan actually has the discretion to determine what medical necessity is. So it's not what you think is medically necessary, it's what the plan thinks is medically necessary. However, in Medicaid and the RFQ that was published that will relate to how behavioral health services are paid for Medicaid beneficiaries, there's actually a section in that document that tells plans that it's not really just up to them to decide what's medically necessary. They actually have to use all the standards and policies that were used by the Medicaid agency, those that have been published by Medicaid, in making any determinations of medical necessity. Under that section 3.9, the plans have to use the level of care guidelines, the locator tool, for making prior authorization and continuing care decisions for substance use disorder services. They have to incorporate the OMH clinical standards of care and the OASAS clinical guidance documents. So they're not completely free here in the Medicaid context to come to their own decision of what medical necessity is. They have to use the Medicaid agency's guidelines and documents in making those decisions as it applies to individuals covered by Medicaid. It might not be a bad thing to actually make sure the definition of medical necessity includes those references to Medicaid's policies and procedures so that it doesn't just say the plan can decide, but that the plan has to decide using and within those documents that have been issued by OMH and DOH and OASAS. Next, we turn to the provider obligations, this next section, which has a lot of obligations for providers. Everything from what services you're obligated to provide to eligibility verification. For example, most plans have systems set up where a patient may present their identification card, but they also want you to confirm that patient's eligibility for services on the date of service through either an online mechanism or a telephone call to confirm the eligibility and verify benefits. Some plans require you to actually receive authorization for any substance use or mental health benefits that are furnished to an enrollee, except in the case of emergency services. This also covers your licensure and certification requirements. I'll say a bit more about that later. Standards of care and quality standards. This is an important provision. The contracts between plans and providers for Medicaid have what's called appointment availability standards. And if this is the first time you're hearing me talk about these requirements, you should go back to one of my prior slide decks, the one that I had dealing with negotiating contracts, and look in Appendix B of that slide deck. There you'll find the appointment availability standards by service type that are basically lifted from Table 4 from the RFQ, telling you how quickly you have to provide appointments and get patients in, and that they have the rights to basically access those services from you. These will be incorporated as part of the standards of care that you are obligated to comply with. There'll be non-discrimination standards that you can't discriminate and treat Medicaid patients, for example, differently than you treat commercial pay patients or vice versa. This is where you'll find the plan's references to utilization management or credentialing, quality assurance, requiring you to follow their procedures for obtaining approval for the rendering of services. As I mentioned, one of the most important issues is scope of services. So when you're looking through the scope of services provision and you're looking maybe even at the exhibit that defines the fee schedule, you should be asking yourself, are all the services that I furnish described in the scope of services? Because you really do want to be paid for everything you do. And so it really needs to be clear in the scope of services what they are agreeing to pay you for. Recently, one of the agencies that I work with in New York was told by a plan that the plan didn't even know that they were an Article 31 clinic. This should be set out in the scope of services, what services you provide, so there can be no misunderstanding of what kind of licensure you have. You want to be paid for all the services that you render, and the plan typically will only include a fee schedule related to the services that they will cover when you submit a claim. In addition, under the state's RFQ for behavioral health services, any clinics that hold a state integrated license, the plan actually has to contract for your full range of services that are available under your license. That could be a helpful advantage to have in defining the scope of services. All products clauses. Some of you may be familiar with this because I think there's been some discussion about this in different associations and in the news lately. But an all products clause is a clause in an MCO agreement that requires a provider to participate in all the products offered by the MCO. The HMO product, for example, the Medicaid product, the commercial product, maybe workers' comp. But what you should know is that each of these products have their own fee schedules. Now, I agree, that doesn't make a lot of sense. It doesn't cost you anything more to render a specific service for an HMO enrollee than it does necessarily for a Medicare enrollee. But plans, I guess, are allowed to sort of discriminate along these lines, and they can pay you differently for different products that they offer. So an all products clause forces you to participate in all the plan's products with each of those individual fee schedules that are offered by the MCO. Both those currently offered by the MCO, but they're kind of tricky here. They also are having you agree to any future products that they might add in the future. So if they add a Medicare product, for example, one of these FIDA products for the fully insured dual eligible population, or a new commercial product that has a different fee schedule, maybe even a lower fee schedule than you're currently paid, an all products clause has already bound you to participate in that product and in that fee schedule without giving you any right to opt out or to negotiate that fee schedule. Now, recently, New York State has announced that the Medicaid MCOs won't be allowed to include an all products clause in their contracts with behavioral health providers. This is good because this would mean that you could say yes to Medicaid but no to maybe a commercial product if you feel the commercial product does not pay you adequately. So New York State has said they'll prohibit it, yet you as a provider can still agree to participate in different products, but you'll have the right to participate and agree to participate individually, product by product, without being coerced to participate in all. Now, I just want to give you one caveat. Until New York State formally amends their contracts with the Medicaid managed care agencies, it would still be a good idea to avoid any contracts that have this all products clause. Essentially, until that contract amendment occurs between the MCOs and the Medicaid agency, really anything is possible. And so while it's great that New York has announced its policy position on this, what we'll really want to see is the contracts that underlie the relationship between the plans and the Medicaid agency. And until that changes, I encourage you to make sure to try to avoid any all products clauses in the contracts so that you have the right to participate and negotiate each product individually. Licensure and verification provision in the provider obligation section will require you to maintain certain licenses and certifications, as well as agree that your employees are appropriately licensed or certified. Typically, you'll have to make representations that if you lose a license or one of your employees loses their license, you'll notify the plan about that change. A couple of points here. First, if you do have notification requirements, sometimes I find these licensure and verification terms written in a very overly broad way. Some of these require you to notify the plan with no more than an investigation occurring by a government body or some allegations made against you. In my view, it's way too premature to be notifying a plan in that situation until you actually have a final decision, until your provider or practitioner has had their case heard by the licensing board. I don't believe you should have to notify the plan. And usually in these circumstances, it's the last thing on your minds to do anyways. You're mostly wanting to take care of your provider, take care of your license, and that's foremost in your mind. So I suggest you read over these notice provisions carefully and maybe scale them back a little bit so that you don't notify the plan until there's actually a loss of license or a loss of certification. In addition, if one of your practitioners loses their license, it shouldn't necessarily jeopardize your entire contract with the plan and give them the right to terminate. It should only terminate that particular practitioner as well. So read over these terms carefully and make sure they make sense to you. Next are the plan obligations. I'm not going to go into much detail here, but I just did want to point out that under this section of the contract, you'll see what the plan is agreeing to do, everything from marketing to enrollment, identification guards, claims processing, and then there are more clinical tasks like utilization review or prior approval and authorization, as well as any grievance and appeals. But this is typically a very short section in your contract, and usually there isn't much modification or change that you'd be making here. The next section, and a very important section, is billing and compensation. And there will be multiple paragraphs within this section. There will typically be a paragraph relating to compensation. There will be another paragraph that relates to your billing procedures, submitting claims. There will be typically another paragraph that relates to the plan's obligations to pay those claims. Another paragraph that relates to any coordination of benefits. If a patient has different health insurance plans, sometimes patients are covered both by Medicaid and sometimes also have a work-related policy or some other policy that wraps around that. And then lastly, recoupment of overpayments. In the event that the plan determines that you have an overpayment, their rights to taking the money back. So let's look at some of the issues that come up in this section. First, copayments, coinsurance, and deductible. In this section, there will usually be language that requires you to collect any required cost-sharing obligation that's owed by an enrollee. If you start discounting or waiving these obligations from time to time or do that routinely, you can get you into a lot of trouble with the plans and actually with potential false claims, because plans have argued that if you routinely waive these cost-sharing obligations, deductibles or copayments, then you're essentially saying that your fee is lower than the amount that you're submitting the claim for. So I don't recommend it. But if you do have a charity care policy where you do reduce or waive cost-sharing obligations for low-income beneficiaries, and you want the ability to apply that reduction in payment to any insured patients, then you'll want to make sure that this provision allows you to do it, because typically the provision bars you from making any cost-sharing reductions. You'll want to make sure the provision is rewritten so it allows you to make reductions or waivers of cost-sharing in the event the patient qualifies for your charity care policy. So particularly if you have patients that may be covered under the insurance exchanges, many of those plans have very large deductibles, and you may find yourself wanting to waive or reduce the cost-sharing obligation for those patients in which the deductible could be a real barrier to accessing care. Another issue you'll find is timely claims filing. Typically, you should have a window to file those claims. Typically, in managed care, it's a 90-day window. you may be used to, if you've submitted claims to Medicaid or Medicare on a fee-for-service basis, that you have up to a year, and sometimes up to a year. But managed care entities don't usually allow that long, usually just 90 days. And the consequences, if you submit a claim after that 90 days, typically they deny it. But, you know, life happens. You may institute a new billing system or some other system that may end up delaying you submitting the claims to the plan. Maybe you don't get the eligibility information at the right time for Medicaid or whatever. I encourage you to think about altering the provision so that the plan may deny the claim to you if it's submitted past the 90 days, but they don't have to. It's not a must or a shall. That will give you some latitude later on in the event that you do have claims that are denied for submitting late. You can make a good faith case, a good cause exception case essentially to the plan, saying that there was a good reason here for why you couldn't submit the claim in time. This is very similar to what the Medicaid agency has. DOH has exception codes that you might be familiar with, where if you submit a claim later than 90 days and you have a good reason to do so, they'll still pay it. That's essentially what you're trying to set up here, so that you can offer a good cause exception, make a good cause exception case to the plan, and they can still pay it. But if you have a provision that makes it the plan mandatory for the plan to deny the claim, you really haven't given them any wiggle room, and basically you will have a very hard time in trying to convince them to pay a late claim. Prompt payment, just as you have an interest in, and plans have an interest in receiving your claims on time, the provider, you have an interest in timely payment. Here it's great that New York has actually passed a prompt payment law that's part of your statutory law. And under this statutory law, all the plans must process within 30 days electronically submitted claims. There's a longer period of time if you still submit claims on a paper basis. If the plan denies your claim that you've submitted, they have to give you written notice of the reason for denied claims. And under the law, you're automatically entitled to interest payments for any claims that are paid after that 30-day period. Automatically, without you even having to go to the plan to ask for it, they are obligated under the law to pay you that interest. Now, in my view, you should have these prompt pay law requirements written into the terms of your contract, not just cited by a regulatory reference, because it's very hard to make your case if you are just citing to the regulation. You have a much better case for arguing for interest or for a notice for why your claim got denied if you can actually point to the document, to your contract with the plan, and say, look, here it is in the contract itself. And since the plan is required to follow the New York prompt payment law, they really shouldn't mind you spelling it out in the terms of the contract. From experience, it's a lot easier just to go to the plan and point to a contract provision than go to the plan, point to a contract provision, which references a legal citation to some regulatory provision, and then say you should have paid me this interest. Much harder case to make. I like going directly to the contract and having it spelled out there. So try to include those legal requirements explicitly, and this also helps inform you so that you know you have a remedy in the event that the plan doesn't provide you adequate notice for the reason for the denied claim or hasn't been paying you interest as they are expected to do. Now, if you do have a serious dispute where for a very long period of time you haven't been paid on time, it's great to have that interest provision written right into your contract, because then you can use that as a negotiating point. You may decide later you'll give up on your right to interest so long as you get paid for all the claims that they haven't paid you for. That's a reasonable position to take, and some providers take that position later on, but have it written into the contract itself. Payment suspensions and reductions. This is an important area that you want to look closely at. Some plans actually have the right to suspend all payments to you simply if the Medicaid agency tells them to do so. This is a little bit scary. You might be familiar with some of your colleagues in New Mexico, which are out of business now, because the Medicaid agency directed the plan there, Optum, who was administering the benefit, to suspend all Medicaid payments to these providers. As a result, these providers couldn't survive without receiving their Medicaid revenue. I think only 3 out of the 15 survived to date. And it was based simply on an allegation of fraud by the Medicaid agency and nothing more. So I encourage you to look really closely to see if there is a provision that requires the plan or allows the plan to suspend payments to you without any due process at all, because it can put you in serious financial jeopardy. Similarly, if the plan is allowed to reduce payments to you simply because they had their payments reduced to them by the Medicaid agency or by Medicare, this can also be unfair to you, and you'll be required to continue providing services at this lower rate. You may be familiar that when the government had sequestration a couple of years ago, they did reduce payments to Medicare Advantage plans, and in some states the Medicaid plans also had a reduction in payments. When this happens, the providers had to continue providing their services at these lower rates. In my view, it's safer, if you're going to have these provisions, the ability to terminate the contract if the plan reduces or suspends payment, because you don't want the obligation to continue to provide services to continue while at the same time having lower payments for those services. You'll want typically to terminate the contract and to stop it in its tracks. So you should revise this provision so it gives you the right to terminate upon suspension or reduction in payments. Third, and this can also be a little bit unfair, is retroactive disenrollments. For various reasons, such as a patient or an individual does not pay their premium, or their employment ends with their employer, or they're no longer eligible for Medicaid, individuals may be retroactively disenrolled from a plan. That is, 5 or 6 months later, the plan might receive notice from the employer or from the state that this individual was no longer eligible for services, and they'll be retroactive to a prior date. Because that person was not deemed eligible for services on the date of service, the plan interprets that as meaning that the person was not a covered person at the time services were rendered, and therefore the services were not eligible for payment by the plan. So the plan retrospectively denies payment, basically determining that the amount that you received was an overpayment, and it deprives you of payment for the services that you were obligated to furnish to the enrollee at the time. This puts you in a significant amount of financial risk because you don't control when an individual is retroactively disenrolled. I encourage you to look at this provision. Some providers are impacted by these retroactive disenrollments more than others, and if you are one of those, then I think that the plan should be financially liable for those services for individuals who have been retroactively disenrolled. To me, this is an insurance-type risk that they have between them and their employer customers, or between them and Medicaid, or between them and Medicare, and this is a risk that they should insure you against, because you clearly can't take the service back from the patient in the event that they are retroactively disenrolled. And many times, if you try to bill the patient for that service, you won't be paid for it. Another provision to look at, or issue to look at, is the correction of overpayments that the plan can make. So let's say they've determined that you have an overpayment because there was an individual that was retroactively disenrolled. Here the plan can take the money back. Typically they do it by offset. That is, they'll just deduct it from the amount that they currently owe you on paid claims. This can be kind of tricky because it can mask whether you actually received an offset. And you have rights under New York law. Under the insurance law in the state of New York, you have very favorable rights. The plan has to tell you that they're going to make an adjustment. They have to tell you the amount of that adjustment. They have to give you a reason, some explanation for why they're making the adjustment. And they have to even offer you the opportunity to challenge that overpayment determination before it occurs. They can't just automatically do it without giving you that right. This is another circumstance where I think these rights should be written right into the contract. In many managed care contracts that I've seen in New York from the behavioral health plans, they don't tell you these rights. Of course, they probably don't want to tell you these rights, but these are your rights under New York law, and it should be spelled out, in my view, in the plan's contract with you so that you know the rights and that the plan knows their obligations here. Another right that you have is that they can't make this adjustment more than 24 months after the original payment was received by you. So that's good as well. In one of the managed care plans contracts in New York that I've reviewed recently, you had 12 months to request any payment adjustments for underpayments, but the payer had no written limit written into the plan contract. So 3 years later or 4 years later, they could decide that you had an overpayment and take the money back then. Under New York law, that shouldn't be allowed since the plan only has 24 months or 2 years that they can go back. So here, very important provision. Make sure it gives you your rights and states the rights that you have. You probably can't avoid having their ability to offset overpayments. Probably can't change their mind on that, but you certainly are entitled to notice before that offset occurs and the right to challenge it, challenge their determination of whether an overpayment actually exists. If the plan provision isn't mutual, that is that you can't actually challenge their payments to you if you received an underpayment, then I would encourage you to think about writing that in. Because if the plan doesn't pay you the full amount or the right amount, you should be able to go back to them and claim any underpayment against them just as well. Next, the regulatory penalty provision. I've seen this as a sort of a new provision that's cropped up into plans contracts over the last few years. As you may know, some plans are starting to be fined by their regulatory agency, sometimes the Medicaid agency, sometimes the insurance agency. You might have even been aware that I think even in New York, the insurance commissioner fined some plans recently because they did not treat mental health benefits the same way they treat physical health benefits, essentially that they were not abiding by the mental health parity rules. So you see a lot more regulatory activities where plans are being penalized. Well, some plans are responding to this by including a provision in their contracts with providers that essentially tells the provider, you have to pay a share of these penalties that are imposed upon me if you had something to do with contributing to the penalty that was levied on me. So for example, a plan could be fined by the Medicaid agency or the insurance agency for having an insufficient network adequacy. Well, a plan could turn around and say, our network was inadequate because the providers did not inform us that they were no longer accepting a patient, or that they had reached capacity, or that a practitioner left the provider's practice group. And under your provider manual with the plan, you might have been required to notify the plan that you were no longer accepting patients or that you had reduced capacity. So the plan could turn around under one of these provisions and say, we got fined, and that was in part because you didn't do your job telling us something, so we're going to roll down these penalties on to you and fine you. The problem from a provider's perspective is that creates a lot of financial risk for you. You don't have any relationship with the state, which fined the plan, so you can't challenge or dispute the penalty that was imposed upon the plan, and you don't know how much you're agreeing to when you agree to this regulatory penalty provision. How much is the plan going to be penalized? How much are they going to roll down to you? How are they going to allocate what you're responsible for versus what the plan was responsible for? So these are very, I think, challenging provisions for providers. The safest thing is to remove these provisions from the contract so that you're only liable to the plan under the indemnification clause term of the contract, which we'll talk about in a moment. But generally, that's the statutory, that's the provision of a contract that makes you liable to them for any claims that are made against them by third parties. In my view, that indemnification provision should cover any circumstances in which you did not do your job and the plan had a penalty imposed upon them. Next, MCO insurance coverage. Just a quick thing to say about that. Typically, you'll have obligations to have insurance coverage. In my view, they should have insurance coverage requirements as well. One of the important types of insurance for plans to have is called reinsurance or stop-loss insurance. This is essentially insurance that insurance plans take out in the event that they have particularly large claims related to one single enrollee. It basically covers some of their losses. In my view, plans should be required under their contracts to have reinsurance or have stop-loss insurance, and you should see that reflected in your contract with the plan. Next, indemnification. As I mentioned earlier, this term is when you are saying that you'll take responsibility for any claims that are made against the other party by third parties. So, for example, in the negligence context, where you and the plan could be sued, let's say, for malpractice, In the event that that happens, maybe the plan was sued in part because the patient or the patient's family knew that the plan had deep pockets, so they sued the plan as well. But if you were really responsible for the malpractice, the plan could sue you later for any part that they had to pay for the patient. Here I think it's important that you just recognize what you're indemnifying or covering for the plan, making sure that you're just covering or indemnifying the plan for things that you do wrongfully, any acts or omissions that arise out of the performance of a contract. You shouldn't be indemnifying them for any of their obligations or responsibilities under the contract. And these should be two ways. Many indemnification clauses that I've reviewed recently by plans are only one way. Here, you are indemnifying them, but they are not indemnifying you. As I mentioned, they should be indemnifying you for any of their obligations. So make sure that they go both ways and protect both of you. The dispute resolution process is important for resolving disputes, obviously. There could be different types of dispute resolution process for different kinds of disputes. Make sure that these are graduated. You know, there's nothing wrong with saying that the first step to resolve any dispute is to meet in person, to have a conversation to try to resolve it before taking any other formal action, before going to mediation or arbitration. My one pointer here is that you shouldn't be required to exhaust any of their internal appeals process before resorting to other measures, because sometimes you can get stymied as a provider. If you have 4 or 5 levels of internal appeals processes from the plan and they don't give you a final decision at the 5th level, that can sometimes preclude you from seeking informal negotiation or mediation or some other right to dispute resolution under the contract because you haven't received final word from the plan. That will obviously stymie you from trying to remedy it using these other methods. So you shouldn't be required to complete their appeals process. If you do have issues with plans and you're not making any headway, don't forget that these plans are heavily regulated by DOH, and there is a complaint hotline you can call, just like employees and enrollees have. You can even email them, and they can try to resolve issues on your behalf. I've seen this happen a couple of times recently where OMH or DOH has sent an email back giving the provider guidance, and that's been useful in resolving an issue with the plan. Now we get into some of the miscellaneous terms that you'll find in the contract. Actually, first term and termination before we get into the miscellaneous terms. The term of the contract obviously states how long the term is. One thing to think about here is that if you've never contracted with an MCO before, and I know many of you that are listening today have no MCO contracts, if that is you, you may want to consider having a short 1-year initial term of the contract where it does not automatically renew. The importance of that means that at the end of that year, neither party is obligated to sort of continue, and it gives you a greater leverage in renegotiating the terms of that contract. Because it didn't have an automatic renewal clause, if the plan wants to keep you within their network, then they essentially have to come back to you to renegotiate the terms. And if you've had any issues that arise related to payment on time, credentialing, appeals, prior authorization, you can address those terms within the contract before actually renewing or before having a second year with them. After that initial period is done, you may well want to have an evergreen clause where the plan contract automatically renews. But one thing to think about, if you have contracts that automatically renew, it doesn't necessarily mean you get a raise each year in the fee schedule. Many of the fee schedules will just stay in place at their existing rates. The contract will renew, and you won't get an increase in rate at all. That can be a problem for many folks because they want to get an increase in fees as their costs go up from year to year. You can try to modify that provision, for example, giving you the right to renegotiate the terms before the contract gets renewed if this is something that's important to you. In regard to termination, there are several different types. You'll see a provision in the contract itself, one that may refer to termination with cause, another which terminates without cause. Typically, when you have a contract, it could terminate for a material breach of particular terms, and then you'll have a notice requirement both parties will be required to notify the other in the event that one party breached the contract, or because one party breached or one party didn't do something right and the other party had the right to terminate the contract for cause or without cause. Let me talk a little bit more in detail what that means. So in the first kind of termination, it's without cause. It's for cause, rather. The contract will list out all the reasons why they may have the right to terminate the contract early before the end of the term, everything from harming patients to you losing your license. What I find in many provider contracts or plans is that the plan has a whole host of reasons for why they can terminate the contract early, but the provider has either a very short list or no rights to immediately terminate the contract for cause. And that's a problem. Let's say a plan goes into bankruptcy or becomes bankrupt. If you don't have the right to terminate the contract immediately or within a short period of time, like 30 days, then that means that you're going to be continuing to be obligated to provide service to their enrollees and submit claims when you know I'm not going to get paid on those claims, or I may only get paid a few cents on every dollar for those claims. You'll want the right to end the contract so you don't start accumulating losses. So it's important that you have a right to terminate the contract for a cause for very similar things that they have a right to terminate the contract for a cause. If they lose their insurance, if they lose eligibility or licensure, if they go insolvent, or if they materially breach the terms of the contract and don't correct them within 30 days. So I encourage you to modify that termination for cause provision, giving yourself equal rights. The second type of termination is termination without cause. This allows you to terminate, or either party to terminate the contract with no good reason at all, just to terminate it because they want to or because you feel like it. Typically, there's a notice period, so you have to terminate without cause and give the other party 60 or 90 days notice. One thing I would just point out is if you have a termination without cause provision, it essentially transforms the term of the contract into the length of time that you have to provide notice, or one party has to provide notice to the other party, because it means either party can end the contract with no reason at all just by giving notice to the other party. So even if you have a year-long term or even a 3-year term of the contract, it really means that you have a 60-day term if you have a termination without cause that simply requires 60 days notice. Here you should just think about whether you'd benefit from the addition or the deletion of a termination without cause provision. If you want maximum flexibility to get out of the contract, then you'll want the termination without cause provision. But if you don't, but it works both ways. It also means the plan has maximum flexibility and they can cut you out of the contract simply with the notice that's required under this clause as well. So you have to figure out which is more important and whether you want the clause or don't want the clause in your contract. When your contracts are terminated, I get lots of questions. Do we continue to get paid if we have any post-termination obligations to continue seeing patients? You actually should be getting paid. Most contracts with plans actually spell out that you have the obligations to continue seeing patients, maybe for the next 180 days if a patient is in your care, or until they transfer care of that patient to another provider. But there's usually a provision that says you'll continue to get paid as you were under the contract when it was before it was terminated. If that provision is missing, certainly make sure that that language is reinserted so that they are obligated to pay you at the rates that were in effect before termination for any services that you provide post-termination. In addition, this is important, you may want to notify your patients that they can continue seeing you or why they're not covered anymore under that plan's contract, and you shouldn't be barred from doing so. If there's language in there that bars you from communicating with your patients about after the termination or about the termination, you should make sure that language is changed so that you can communicate with the patient. The last thing you want is charges of patient abandonment or confusion about why you're no longer participating in that plan or where the patient may want to go for services. There shouldn't be any prohibition on you, in my view, in your communications with a patient. Now we move to some of the other sort of miscellaneous terms. So one term that you'll often see is assignment. In this type of provision, the plan can typically assign the contract. So if they're bought by another entity, if they merge with another entity, they typically will want to retain their provider network. You may not want to be part of this other plan's provider network that buys them out for various reasons. Maybe it's not a plan with a good reputation or whatnot. Typically, though, these assignment provisions are written so that they don't have to get your consent. You may want to consider whether you want to actually consent to their assigning your contract to another plan that buys them out or that they merge with. Or maybe you don't need consent, but you want to have the right to terminate the contract if they assign your contract to another plan. Something to think about. Very important is the amendments clause to the contract. I'm still surprised when I see contracts come before me where the plan can amend the contract unilaterally on their own without getting the other parties, getting the provider's consent. I don't find that to be much of a contract. You know, if you have a contract with me for how much you're going to sell your house to me for, and you can change the purchase price at any time, I'm not going to feel real good about that contract because you could change it at the last minute from $1 to $1 million. In the same way, I don't think plans should have the right to amend their contracts without getting your consent to do so. So you want to make sure that if there's an amendment clause, that you have the right to consent to any changes that they're making under the contract. Sometimes you'll see language in there where you'll only have consent or the right to consent for material changes to the agreement. However, my concern with that is a term might be material to you, but not material to the plans, and there could be a dispute about whether something was a change that was material or not. In my review, it's then better just to require any changes, all changes, to require your consent. You know, if a plan is concerned that it would be too cumbersome or too burdensome to get every provider to sign an amendment, then you can just respond that there can be an auto amendment clause where you're offered an amendment, and unless you object within 30 days, the amendment goes into effect without your signature. That way the plan doesn't have to run around and get everybody's signature. And I do see that in some plans contracts with providers. If you have a provision like that, that's okay, but you should still, again, be allowed to object if you don't agree to the amendment. And if you do object to the change or to the amendment, in my view, the contract should continue under the original terms of the agreement. In some amendment contract provisions with plans, if you object to the amendment, it allows the plans to terminate the contract with you immediately, or you are automatically terminated from the contract. To me, that's not fair. Simply because you refuse an amendment shouldn't result in you losing the contract or being forced to terminate the agreement. It should just continue like it normally did. The other thing you want to look at is to see whether the rights are even mutual. A plan may have the right to amend the contract, but you may not. To me, that doesn't seem fair. Both parties should have equal rights to amend the contract under similar terms. One thing just to point out, there will be usually a provision that allows a plan to amend the contract without your consent if the change is required by law or regulation. That's fair. That's fair in my view. If a plan has to do something because the law changes, then it shouldn't be necessary to get your consent. That change in law or regulation should just flow down to the contract, flow down to you. And that's the only time that they shouldn't have to get your consent. The notice clause, you may not think this is an important clause, but it actually is quite important. That notice clause is the one that typically puts in the address and where you have to notify the other party for official notices to take effect under the contract. There's been lots of mistakes I found with notice clauses. In one provider's contracts that I reviewed, the clause said that notice should be delivered to the address set forth on the signature page of the contract. Then when I went to look at the signature page, there was no address listed or set forth on that. In another example, it said notice should be sent to the address set forth in the preamble to the agreement, and then there was no address set forth in the preamble to the agreement. That doesn't help. In my view, have a good notice clause which actually describes and indicates exactly how you should communicate the notice. That is it written notice? Is it email? How the notice should be delivered, courier service, certified postal mail, electronic delivery, and the name of recipients or recipients and their address. Now, people come and go at different organizations. Providers change their CEO, plans change their CEO. It may be worthwhile not having a particular name, but actually having a title of an individual who should receive notice under the contract. You may even want to have two individuals receive notice. There's no requirement or rule that says you can't have two individuals named at the provider who should receive notice of any official changes. Just make sure it has the correct name and title of the individual who should receive notice so that there's no ambiguity. In some cases where plans have proposed amendments to the contract and given a provider 30 days, that notice unfortunately did not end up on the CEO's desk. It went to maybe the billing person who filed it away in their filing cabinet, and the provider missed their chance to object to the addition of a new product or a new fee schedule. Don't let that be you. Make sure your notice clause is clear and has the right title and the right person in the notice provision. And now we move to the exhibits part of the contract. This is really the third part that I mentioned when I began. And this is where you'll find so many significant terms that you'll want to look at. It's okay to have a sneak peek at the exhibits before you look at the rest of the contract, like I do. It should spell out, have an exhibit that has what services they're covering under the contract. It may have an exhibit about your particular locations or the practitioners that will be covered. It may have an exhibit of what products, or may have multiple exhibits, an exhibit for each product that they offer, one for Medicaid, maybe one for the dual population, maybe one for commercial, and then each of the associated fee schedules. Make sure everything is complete. Recently I was looking at the fee schedule for one of the provider contracts, and they referenced payment rates set forth in Exhibit C. And then when I went to look for Exhibit C, the table was missing that should have had the payment rates. In another case, it said payment rates set forth in Exhibit A, and it had a fee schedule that was dated July 2007. That's an awful long time ago. You'll want to make sure that you have an updated current fee schedule. Codes have changed a lot since 2007, and there was a whole change of codes back in 2013. So make sure you have an updated and current fee schedule that pays you at the going rates. As you look through the exhibits, again, make sure they are entirely complete. In regard to the regulatory appendices, you'll see an appendix that's required by DOH. You'll probably see an appendix that relates to Medicare Advantage if the plan offers a Medicare Advantage product. Those terms, it's really not worth looking at those in much detail because those terms are non-negotiable. These are regulatory appendices or requirements that are imposed upon the plan by the payer, by Medicaid or by Medicare. So it's not worth trying to propose changes to those because the plan won't have any discretion to change the terms in those exhibits. I think that's the last slide here. I wanted to mention before Dan chimes in that the sample agreement that you'll see that will be sent out and that you'll be looking at contains terms from real agreements. It's not as long as a real agreement, so don't be worried that you're going to see a 35 or 40-page or 80-page contract. What I've done is slim it down and almost included all the potentially disadvantaged or disadvantageous terms in a single 8 or 9-page sample contract. So it's not a real complete contract. It just has pieces taken from actual real contracts related to issues that I've discussed and covered on the webinar today. So again, don't worry, it's going to be a long 40-page contract. It's a much simpler contract to review, but it does have all the key provisions that an actual contract would have. All right, Dan.
Great. Thank you so much, Adam. And I don't know about everybody else. Maybe it was the strong cup of coffee I had this morning, but I'm still wide awake, so that was great.
Good to hear.
We've had a few questions come in while we've been chatting, so we've got about 10, 15 minutes left. So I'm going to just quickly remind people how the workshop outline is looking, and then we'll jump into a few of the questions. And again, we'll have an office hour scheduled in early July. The save the date for that is July 8th. We've got a couple of moving pieces before we confirm and send around a registration link, but if you'd like to add to your calendars as a placeholder, we encourage you to do that at this point. But so just again, so what we'll be doing after today is sending around the sample contract, the assignment or exercise that Adam and I have spoken about, as well as the questionnaire that you'll use to fill out to submit some answers and questions that are arising as you're working through it in the next day or so, along with a recording of today, the slides from today, and also we'll throw in there some links to some of the resources that we've mentioned during this presentation, just so folks have that all in one place. And then again, we'll ask folks to complete that assignment and submit responses by Monday, July 20th at 5 p.m. So that's over a month away from today. So hopefully that gives people plenty of time to work through the contract with their teams at their respective agencies and come up with some really interesting questions and insights. And then we'll have the wrap up with assignment review at the end of July. Again, please save the date. We don't have a registration link for it yet, again, because of a couple of moving pieces, but we hope to have all of that solidified in the next week or so and out to everybody as soon as possible. So with that, let's jump into a few of the questions that have come through. So first off the top, Adam, somebody wanted to know, how often will your request to modify a contract, for example, adding an advance notice of changes to a provider manual, actually be agreed to by the Medicaid managed care company?
That's a great question, and I often get the question because people are wondering, is it sort of worth their time to make requests, or is the plan just going to say no to everything that they propose? And really, to answer that question, you should go back and listen to some of the webinars or the in-person training I've done on negotiating the contract, because you do have some leverage with the providers, and it's helpful to know how much leverage you have before you actually propose amendments or changes to the contract back to the plan. You know, for example, you can imagine if you're providing a service and you're one of, a couple of other providers in your county that furnish the service, and the plan has to contract with you to meet their network adequacy requirements, you have a lot more leverage to make changes on the provider than you would if you didn't have that kind of leverage. And there's lots of other types of providers that they could contract with and substitute services from. The other thing you have to understand is sort of the impact that that change may have on the plan and how easily they could adjust to it. In the negotiations webinar and training I've done, I've said it's really important to ask them a lot of questions. And so rather than simply sending something back and saying, for example, we require notice of 60 days in advance to changes, it may be more helpful to frame that differently as more of a question. Ask back to the contract representative something like, I see here you have the right to make changes to your provider manual. That totally makes sense to me. But how much notice do I have? It would seem to me that I would need some notice in order to comply with those changes in advance. How does that work? And you may find from that discussion that they say, oh, yeah, well, we routinely provide notice of, 30 days. We couldn't impose requirements without telling you them in advance. And then you have an opening to say, oh, that does make a lot of sense. Can we write that into this contract here? Any reason why we can't? And at that point, it doesn't seem like such demand. It seems like a very logical next step.
Great. So moving on, so contracting typically happens at the agency level, but should contracts list or have the respective program names as well?
I don't know what you mean by that question. Dan, do you understand it?
Should the contract have the agency name or should it have the agency's program name? So if contracting happens at the agency level, should the contract explicitly list out the respective programs that are under the agency umbrella?
Oh, I see. Right. And I was talking about having the legal name of the entity in the contract. So it should be the legal entity, the legal name of the agency that is making the contract, not the sort of the respective program or department within that agency, because what has legal standing essentially is the legal entity itself, not the sub-department or subdivision within that agency.
Great. We've got a couple of policy legal questions that have come through. So if you need to refer back to something, we can always add these to the Q&A or the office hours. So So one thing is Medicaid held to the offset law time limit? So this person recalls that Medicaid can be recouped for services delivered 3 years previously.
So there's different rules that apply depending on whether there's an allegation of fraud, first of all. So there is an exception for fraud. And then it is worth going back and looking at the RFQ to see if they've changed the amount of time for recoupments and whether it's a deadline that applies in the fee-for-service context versus a deadline that might apply in the managed care context. In most cases, many of these plans do have a commercial product, and as an insurance entity, those rules do govern their conduct. But this is actually a good one for office hours, so let's sort of hold that question for office hours, and we can cover that in the office hours.
Great. So stay tuned, everyone. Thanks, Adam. If you have already signed a contract, is it too late to modify?
Well, probably it is, unfortunately, because if you have the typical standard contract from the MCO, you really don't have the right to amend the contract. Only they do in the standard contract that's probably been issued to you. And you would have to essentially either wait to the end of the term of that contract or if you have a termination without clause provision in your contract, you could send them a letter saying, you know, we intend to terminate this contract without cause effective, 2 months from now, unless we can come to a change in or favorable, mutually agreeable terms relating to, and then fill in the blank, so that essentially you could terminate the contract early. But you wouldn't be able to simply amend the contract under most of the standard terms that are included in MCO agreements.
Great. And then do changes to the base contract, or if you work with an MCO to make changes to the contract that they're supplying, do those have to be reviewed and approved by the New York State Department of Health or any other bodies prior to being executed?
So yes, the plans actually have to have their contracts approved by DOH, and there's probably a little bit of debate about whether it just includes substantive changes or all changes to the contract, whether it's just to the contract template and form, or whether if they make certain allowances or changes for plans, they have to go back to DOH. For example, you can imagine that there are several providers that get paid different rates for the same services. Does the plan actually have to go back each time they modify a payment exhibit and they want to change the rates? Probably not, and probably the plan would say that they're not obligated to do that. So I think it's going to depend on what clause in the contract is being changed, and then the plan's sort of interpretation of when they have to get approval. And there's nothing wrong with them getting approval. If they make a change to the amendments clause in their contract and they have to send it back to the state to get approval, it doesn't mean that the state's going to deny that change. It just means it's an additional hoop for the plan to go through. Of course, if the plan had more favorable terms to begin with that were more essentially provider-friendly, then they could just have a friendlier contract approved by DOH initially so that they didn't have to go back to the state each and every time a provider wanted a change in term.
Gotcha. That's helpful. Just another question or two before we wrap up. So if an agency's scope widens, and they provide more services during the contract term, where would a provision to add to that be included in a contract?
So it wouldn't be included in the contract, but what you would want to do is to notify the plan that you've added a service or you have a new service and request the plan to essentially request them to amend the contract to include the contract. So let's say you have now ACT or PROS or some new service that you didn't have at the time you entered the contract. You would go back to them and say, hey, we're offering this service now. We'd like to get this added to our scope of contract. And very likely they will send you an amendment that will modify and include that service within your contract.
Great. And then a general contracting question where a provider seems to be having an issue with their program location being in a separate space from their billing location or their billing address. And so the plans send authorization approvals to the billing location, which is also home to a number of other programs. so the program itself often doesn't know, when they've been approved for authorization until they see an EOB. So do you know if of a way for plans to either electronically or hard copy send authorizations directly to a program address in addition to the main billing address?
I don't, but that's an important technical question that you'd want to go back to the plan. That would probably be described in their provider manual, and that you'd want to work out to see whether you could have notice sent somewhere else, because the notice clause in the contract, the clause that I reviewed, really relates to official notices under the contract that relate to the agreement. So, for example, notice to the other party to terminate, notice to the other party of breach, notice to the other party for amendments for the contract. It doesn't apply to notice for the other party for prior authorizations, because that's not a what I would call a required kind of notice under the agreement itself. So, but I agree, there should be a way that a provider can, when they're requesting an authorization, that goes to a specific individual or specific site where services are being rendered.
Great. So we received a few last questions, and I'll actually take a stab at this one to give Adam a bit of a breather as we wrap things up, about communications with plans in New York State, or difficulties getting in touch with people, or misconnections as we'll call them. And so who do you reach out to at the respective plans if you haven't heard yet, or if you're not in contact already about contracts? So based on some really helpful suggestions from folks during the kickoffs and then also the Contracting in-Person event series, we have been spending the last couple of months developing an online interactive tool for folks that lists all of the MCOs that are contracted by New York State in the respective counties and regions, with a robust amount of information about their contracting process, about who to contact, phone numbers, email addresses, and this, goes, and kudos to the plans for providing this level of information in one universal place. This goes well above and beyond, like, the generic 1-800 number that you might call and have to be bounced around and redirected to a bunch of folks. So we're hoping to have that go live by the end of the month is our goal. We're just finishing up the beta testing and making sure that all of the information is accurate and complete for folks, and then we'll be updating that on a quarterly basis. So folks should stay tuned to that, and that should be a really great and useful tool as people are working through their contracting process, as well as some of the other nuances of Medicaid managed care in the new environment. So with that, we will look forward to talking with everyone again on July 8th from 12:30 to 1:30 for the office hour. Again, please save the date for that. We'll be sending a registration link around soon. And also keep an eye out in the next day or so for a follow-up email coming from today's presentation with the contract exercise, the survey link, and then links to resources from the Kickoff Series, Contracting in-Person event series, and a few other things that might be helpful to review to inform the process as you're working through this. And again, one last reminder to please send any questions around the assignment or around contracting in general ahead of the workshop to mctac.info@nyu.edu. And just if you can, put in the subject line contracting workshop or contracting workshop assignment just to help us keep track of all of the requests that come through. So again, I'd like to thank our presenter, Adam, for doing a fantastic job today. And then we will look forward to talking to everyone again in early July. Thanks so much.